Imagine for a moment just how challenging it must be when even a slight movement brings sharp pain,
Yeah.
where a simple turn in bed, maybe a step to the side, feels like, well, like climbing a mountain.
Right. And for anyone in healthcare, really getting that experience, the impact of immobility, is just fundamental.
Absolutely. It's so much more than just a physical thing, isn't it?
Oh, definitely. Immobility creates this ripple effect. It touches nearly every system in the body and really affects a patient's whole sense of well-being.
Exactly. And that's what we're doing today. Welcome to the deep dive. This is where we unpack complex topics, add a bit of curiosity, some critical thinking, and pull out the most important insights for you.
Hmm.
Today, it's a deep dive into something really crucial for your nursing journey, the profound effects of immobility. And our insights are drawn straight from Fundamentals of Nursing, the 11th edition, by Potter, Perry, Stockert, and Hall.
And our goal here is simple. Cut through that, dense textbook language,
Yeah.
give you a clear shortcut to understanding the core ideas about immobility.
So you'll learn what it really means for your patients, how it hits every body system, and maybe most importantly, how you as a future nurse can actually prevent and manage its consequences.
Right, across all settings too. Hospitals, community care, home care, it's everywhere.
Think of this as your guide to essential patient care, those critical
Mhm.
safety protocols, decision making, stuff that's directly relevant for your NCLEX and, day-to-day practice. Okay, let's get into it.
Let's do it.
First up, the nature of movement itself and the maybe hidden cost of immobility. So, mobility, what is it?
At its core, it's just the ability to move freely, right?
Yeah.
And it's so closely tied to good patient outcomes because,
Yes.
well, we need it for almost everything. ADLs, activities of daily living like
Yeah.
dressing, eating.
Work, leisure,
Yeah,
even how we communicate sometimes, non-verbally.
exactly. And for that to happen, our musculoskeletal system and our nervous system, they have to be working together smoothly, perfectly in sync, ideally.
And when that ability gets compromised, that's immobility, the inability to move freely.
And it's not black and white, is it? It's a continuum. You've got full mobility on one end, total immobility on the other, and like loads of variations in between.
You hear terms like bed rest or impaired physical mobility all the time.
Right. And sometimes bed rest is actually therapeutic. It might
Yeah.
be prescribed to, say, decrease oxygen needs or reduce the heart's workload, maybe manage severe pain.
But here's something that honestly surprised me a bit when reading this. Nurse researchers found patients often limit their own activity voluntarily.
Hmm. And why is that?
Well, apparently they're afraid of bothering the staff or they don't want to feel dependent. Maybe they even see asking for help as like a negative thing.
Wow. That's a really powerful insight. It makes you think, doesn't it?
Yeah.
How do we as nurses create an environment where patients feel empowered to move without those fears?
Yeah. And speaking of moving patients, doing it safely for them and for us, that brings us to body mechanics.
Ah, yes, body mechanics. The coordinated effort of our muscles, bones, and nervous system. And historically, well, let's just say lifting and positioning used to cause a lot of injuries for nurses. Debilitating ones.
Oh, absolutely. The stats even now show overexertion, improper handling. There's still major causes of nurse injuries. It's a huge issue.
So current practice, the evidence-based approach, it really emphasizes using what we know about body alignment, balance, gravity, friction. Using that knowledge for safe positioning, assessing fall risk, safe transfers.
Okay, let's quickly break down gravity and friction. They sound simple, but they're key.
Right, gravity, that downward pull. If a patient's center of gravity gets displaced, boom, they can fall.
And friction.
That's the force opposing movement. So think about moving a heavier patient, more surface area. Touching the bed means more friction, more resistance you have to overcome.
Which leads directly to something called shear. This is super important for skin integrity.
Explain that a bit more.
Okay, so shear happens when the bones inside move, but the skin kind of stays put or lags behind. Like, imagine a patient sliding down in bed when the head's elevated too high, maybe over 60 degrees.
Ah, I see. The skeleton moves, but the skin gets stuck on the sheets.
Exactly. And that stretches and tears the tiny blood vessels underneath, cuts off blood supply. And that damage is a direct route to pressure injuries, even if the skin looks okay on top at first.
Ouch. So what's the practical solution?
Ergonomic assistive devices, things like full-body hydraulic lifts. They actually lift the patient clear off the surface.
So no friction, no shearing.
Right. Protects the patient's skin and saves the nurse's back. It's a win-win for patient safety and staff safety.
Makes total sense.
Okay, so now we understand the basics of movement and the immediate physical forces. Let's dive into the systemic effects of not moving, that Whipple effect you mentioned.
Yeah, it really does cascade through the whole body. Even short periods of inactivity can cause pretty significant problems.
Where does it hit first?
Usually the musculoskeletal system. Makes sense, right? Our bones aren't just scaffolding. They're involved in calcium regulation, making red blood cells.
And immobility messes with that.
Big time. Bones start losing density. That leads to osteoporosis and a much higher risk of pathological fractures, basically, bones breaking because they're already weak from that impaired calcium metabolism.
We also see things like postural abnormalities getting worse, like scoliosis or kyphosis, or even those really severe neurological postures like decorticate or decerebrate posturing.
Which signals serious brain injury, yeah. And then you have conditions like hypotonia that decrease muscle tone you see sometimes with cerebellar damage, or movement disorders like Parkinson's. They all directly impact mobility.
And of course, obvious things like trauma, broken bones, or joint diseases like osteoarthritis, rheumatoid arthritis. They cause pain, they limit movement immediately.
And even if the immobilization is temporary, say for healing a fracture, that muscle atrophy and joint stiffness can set in really fast. Managing that's a huge challenge.
The sheer speed of deconditioning is kind of startling, losing like 3% of muscle strength per day on bed rest.
It's incredibly fast, and that triggers major metabolic changes. The body's whole endocrine system gets disrupted, metabolic rate slows down, nutrient processing goes haywire.
You mentioned negative nitrogen balance earlier. Can you unpack that?
Sure. It basically means the body is breaking down more protein from muscle than it's taking in or building up. Nitrogen is a component of protein, so when you excrete more than you ingest, it's a sign the body's literally consuming itself.
Leading to weight loss, muscle wasting, weakness.
Exactly. And you also get increased calcium resorption from the bones leaching calcium into the blood, which can cause hypercalcemia. And then GI issues are super common, especially constipation. If that's not managed, it can progress to fecal impaction.
Okay, what about the lungs, the respiratory system?
High risk here. Two big things. Pulmonary atelectasis, which is the collapse of those tiny air sacs, the alveoli,
Because airways get blocked.
right, often by secretions. And that leads to the second thing, hypostatic pneumonia. Basically, inflammation from those pooled secretions sitting in the dependent parts of the lungs when someone's lying down.
Like a breeding ground for bacteria.
Precisely. And it directly impacts oxygen levels. Not good.
Moving to the cardiovascular system, what are the main concerns?
Orthostatic hypotension is a big one. That's when blood pressure drops significantly when a patient stands up or sits up too quickly.
Causes dizziness, lightheadedness, risk of fainting.
Yep. Also, the heart itself actually has to work harder when someone's on prolonged rest, but it does so less efficiently. Increased workload.
And then the really scary one, blood clots, thrombus formation.
Yes. A thrombus is that clump of blood components sticking to a vessel wall.
How do those form? I remember hearing about Virchow's triad.
Exactly. Virchow's triad helps us understand the three main factors. First, damage to the vessel wall, like from surgery. Second, altered blood flow, think sluggish blood flow, or stasis, pooling in the legs during bed rest.
And the third.
Alterations in blood constituents, like changes in clotting factors that make the blood thicker or more likely to clot.
And the major danger is a piece breaking off.
Right, especially from a deep vein thrombosis, a DVT. If a piece breaks off, it becomes an embolus, and if it travels to the lungs, that's a pulmonary embolus, PE. It blocks blood flow there.
Which can be fatal.
It absolutely can be. That's why DVT prevention, especially around surgery, is so critical for nurses. Your vigilance is key.
Okay, circling back to the musculoskeletal system beyond the bones, we talked about muscle strength loss.
Leading to disuse atrophy, yeah, muscle fibers shrink. And that causes fatigue, increases fall risk. But even more concerning are joint contractures.
These are permanent.
They can be. It's an abnormal fixation of a joint. Often the flexor muscles are stronger, so they pull the joint into a bent, non-functional position. Think of someone curled up, almost in a fetal position.
And prevention is key.
Absolutely essential. Once a contracture forms, it's very difficult, sometimes impossible to reverse.
You mentioned foot drop earlier. That's a specific type.
It is, and it's really debilitating. The foot gets stuck pointing downwards in plantar flexion. The patient can't lift their foot to walk properly. You see it a lot with paralysis like hemiplegia after a stroke or nerve damage.
Let's talk about urinary elimination. How does lying down affect that?
Gravity isn't helping urine drain from the kidneys into the bladder. So urine can pool in the renal pelvis. That's urinary stasis.
Which increases infection risk.
Definitely. Higher risk for UTIs and also for renal calculi kidney stones, basically, often made of calcium because of that altered calcium metabolism we talked about.
Okay. And the skin, the integumentary system.
Immobility is probably the single biggest risk factor for pressure injuries. We mentioned shear already. It's caused by prolonged pressure, cutting off blood supply ischemia, especially over bony areas like the sacrum, heels, hips.
Aggravated by sheer friction?
And things like moisture, poor nutrition make it even worse.
Yeah.
The key takeaway here, prevention, prevention, prevention. It's so much easier and less costly to prevent these than to treat them. Your assessments are vital.
And finally, we can't forget the psychosocial effects.
No, they're huge. Immobility can be incredibly isolating. Think social isolation, loneliness, depression. Patients worry about their health, their finances, their future.
And lack of stimulation.
Leads to sensory deprivation. That can manifest as restlessness, sometimes even increased aggression, difficulty sleeping.
And you mentioned something really important earlier about confusion.
Yes. Sudden changes in personality, like new onset confusion or delirium, especially in older adults after surgery, should ring alarm bells. Don't just dismiss it as sundowning or dementia. It's often physiological.
Meaning it has a physical cause.
Exactly. It could be UTI, it could be hypoxia from atelectasis, it could even be a PE. It needs immediate nursing assessment, not just acceptance.
And quickly, thinking about developmental considerations, immobility hits different age groups differently, right?
For sure. Little kids might have delayed gross motor skills. Teenagers might feel intense social isolation. For older adults, you see faster bone loss, higher fall risk, sometimes made worse by medications affecting balance, and just a general functional decline, especially if they're hospitalized.
Which leads to a crucial point for us as nurses.
Don't inadvertently make it worse. Be careful not to provide too much help when a patient could do something themselves. Encourage that self-care, that independence. It preserves their function and their dignity.
Okay, so we've painted a pretty detailed picture of the risks. Now, how do we, as nurses, actually tackle this? That brings us to the nursing process, our roadmap.
Right. Assessment, diagnosis, planning, implementation, evaluation, the whole cycle.
Let's use a case to illustrate. You mentioned Ms. Carnella Cavallo, 81 years old, recovering from surgery for a fractured hip. She also has osteoporosis and pain, 6 out of 10 with movement.
Okay. So Joseph, her case manager, starts his assessment. He considers her age, the surgery, the osteoporosis. But what's great is his approach. He asks her about her goals, wants to go home, wants to garden.
Patient-centered from the start. Partnership.
Exactly. So his assessment finds stable vitals, full arm ROM. But yeah, slow movements, that pain, limited motion in the affected hip and knee. And importantly, that blanchable redness over her sacrum and heels. Not broken down yet, but a warning sign.
That's recognizing the cues.
That's assessment. And it starts with understanding the patient's perception. What are their limitations as they see them? What do they expect? Always show respect for their preferences.
Key assessments we need to perform.
Range of motion, ROM is crucial. Check all joints. Stiffness, swelling, pain, limited movement.
And there are different types of ROM exercises.
3 main ones. Active ROM. Patient does it all themselves. Active assisted ROM. Patient does what they can. You help support them, maybe due to weakness or pain. And passive ROM. You move the joint because the patient can't or isn't supposed to.
Any tips for passive ROM?
Go slow, be smooth. Only move to the point where you feel resistance. Never force a joint beyond that. Repeat each movement about 5 times, maybe 2-3 times a day. Support the limb above and below the joint you're moving.
What else do we assess?
Activity tolerance. How does the patient respond physically to activity? Check their baseline heart rate, breathing, blood pressure, then monitor during activity like walking. See if they get short of breath, dizzy, if their heart rate spikes too much.
Gait.
Yep, observe their gait, how they walk. Rhythm, speed, stride length. Tells you a lot about balance, posture, independence. And always check body alignment, standing, sitting, lying down. Poor alignment increases risk for injury.
So that head-to-toe assessment for immobility complications. What are the highlights again?
Okay, quick recap. Metabolic track, I know, look at lab values like electrolytes, protein, BON. Watch wound healing, diet, respiratory. Listen to those lungs every 2 hours, especially the bases, for diminished sounds, crackles, wheezes.
Cardiovascular.
Monitor for orthostatic hypotension, take BP, lying, sitting, standing if possible. Check pulses, capillary refill, look for edema. And that critical DVT assessment. Use a validated tool like the Will score. It lists risk factors like active cancer, paralysis, recent surgery, tenderness, swelling.
And measure the calves.
Daily. Bilateral calf circumference. If one calf suddenly swells more than 3 centimeters compared to the other, that's a big red flag for a DVT.
Okay. Skin.
Integumentary. Constant vigilance. Use a tool like the Braden scale. Check bony prominences frequently for redness, breakdown, elimination. Monitor I&O, bowel sounds, frequency, consistency.
And psychosocial.
Observe for depression, anxiety, isolation. Use screening tools if needed. And remember, sudden confusion needs investigation. Assess their coping, their social support.
Got it. So after gathering all that data,
Analysis and nursing diagnosis. You put the pieces together, critically analyze the cues to identify the problems. Diagnoses like impaired mobility, risk for disuse syndrome, acute pain, risk for impaired skin integrity.
for Miss Cavallo, her pain, her limited movement, needing help, that red skin, led Joseph to diagnoses like acute pain, impaired mobility, risk for impaired skin integrity. Makes sense.
Then comes planning and outcomes identification, setting goals. And this absolutely has to involve the patient. Set realistic, measurable outcomes together. Remember Ms. Cavallo wanting to garden? That became the overarching goal, leading to specific outcomes like pain control below a 310, being able to transfer with minimal assist.
Teamwork is huge here too, right?
Essential.
Yeah.
Nurses delegate appropriate tasks to assistive personnel, AP. We collaborate constantly with PT, OT, dietitians, wound care specialists, social workers, maybe mental health professionals.
And discharge planning starts.
On admission, always be thinking about what the patient will need to go home safely.
Okay, assessed, diagnosed, planned. Now, implementation. Taking action.
Let's start with health promotion. First off, protecting ourselves. Nurse injuries are common. Follow safe patient handling policies. Use those mechanical lifts. Get help from lift teams. Minimal lift policies are key.
Promote exercise for everyone.
Yes. For well-being, endurance, strength, reducing chronic disease risk, consider cultural factors when planning exercise, and specifically for bone health, especially osteoporosis. Education on screening, calcium, vitamin D, weight-bearing exercise, fall prevention. Use teach-back to confirm understanding.
Now for interventions in acute care, system by system.
Okay. Metabolic. High-protein, high-calorie diet often needed. Maybe vitamin supplements like B and C for energy and wound healing.
Yeah.
Respiratory. Encourage deep breathing, incentive spirometry, controlled coughing every 1-2 hours. Push fluids like 1100, 1400 milliball daily, non-caffeinated to keep secretions thin and easy to cough up.
Cardiovascular interventions.
To reduce orthostatic hypotension. Get patients moving as soon as safely possible, even just dangling legs at the bedside, then moving to a chair. To reduce cardiac workload, teach patients not to do the Valsalva maneuver holding breath and straining like during a bowel movement. Why is that bad?
It increases pressure in the chest. Then when they release their breath, blood pressure can drop suddenly. Heart rate can slow way down, potentially dangerous, especially if they have heart disease. Tell them to breathe out during exertion. And preventing clots, the thrombus formation.
Early ambulation is best, but also anticoagulants as ordered and mechanical methods like SCDs, sequential compression devices, or MCDs, mobile compression devices.
Those inflatable leg sleeves.
Right, they inflate and deflate cyclically, squeezing the legs to push blood back towards the heart, preventing stasis. Use them right after surgery until the patient is fully walking.
What about elastic stockings? TED hose.
Anti-embolic stockings, yeah. They provide continuous pressure to promote venous return. Key things. Measure correctly for the right fit. Apply smoothly. Turn them inside out first. Usually make sure there are no wrinkles. And remove them regularly to check the skin. Don't use them if there are skin lesions or signs of a DVT already present.
And the crucial safety point.
Never, ever massage a leg if you suspect a DVT. You could dislodge the clot. Deadly mistake.
Got it. Teach leg exercises too.
Definitely. Simple things like ankle pumps. Point toes up, then down, foot circles, bending knees. Do them hourly while awake.
Okay, maintaining musculoskeletal function.
Regular ROM exercises, active, active-assisted, passive. Great time to do them is during a bath. Use positioning devices. Friction-reducing sheets make moving patients easier. Use pillows correctly. Specialized things like foot boots or AFOs, ankle-foot orthotics, to maintain dorsiflexion and prevent foot drop.
What's a trochanter roll?
You make it with a bath blanket, folded and rolled. Place it alongside the hip, from the crest of the ilium to mid-thigh. It prevents the hip from rotating outwards when the patient's lying flat. Hand rolls or splints maintain a functional hand position. A trapeze bar overhead lets patients use their arms to help reposition themselves.
And the key patient positions.
Supported Fowlers. Head of bed, 45-60 degrees. Good for breathing, eating, supine, flat on back, prone, face down. Not common, but sometimes used for severe respiratory distress like ARDS or COVID-19 to improve oxygenation. Side lying, lateral. Weight on hip and shoulder critically. Use a 30-degree lateral position to keep pressure off bony prominences like the sacrum and trochanter. Best for pressure injury prevention.
How do we move patients safely?
Always ask them to help as much as they can, assess their ability, cooperation level, comfort. If they can assist partially, use friction-reducing devices, draw sheets. If they can't assist, use mechanical lift. Always protect their heels from shearing when moving them up in bed.
What about log rolling?
That's for patients who need their spine kept straight, like after spinal surgery or injury. Takes usually 3 nurses. You move the patient as one single unit, like rolling a log, using a draw sheet. Pillows between the knees and along the back for support once turned.
Integumentary skin protection.
Reposition frequently, at least every 2 hours in bed. Use pressure-reducing mattresses or overlays. Meticulous skincare. Teach patients in chairs to shift their weight every 15 minutes. For Miss Avalio, Joseph ensured she was turned regularly and had the right mattress. Elimination. Psychosocial.
Elimination. Push fluids like 800, 2000 milliliter non-caffeinated daily. High fiber diet. Use toilet aids if needed. Psychosocial. Provide meaningful things to do, encourage visitors, involve family, help them participate in their own care hygiene. Grooming maintains dignity. Like Joseph getting Miss Cavallo those books and puzzles, that connection matters.
Developmental needs.
Age-appropriate stimulation, play for kids, encouraging ADLs for older adults.
Then, in restorative and continuing care, the focus really shifts.
Right. Maximizing functional mobility and independence, not just ADLs, but also IEDLs, instrumental activities like shopping, cooking, managing finances, often involves intensive PT and OT.
And assisting with walking.
Yes. Teaching them to use walkers, canes, crutches correctly, crucial safety, always use a gait belt, stand slightly behind and to the side, usually the weaker side, and never just grab their arm for support. You could dislocate their shoulder if they stumble.
Good point. So Miss Cavallo's progress.
She did well. With pain meds on board, she transferred to the chair with help. And Joseph's thoughtful approach with the books helped keep her spirits up. It shows how holistic care works.
Absolutely. Which brings us to the final step, evaluation.
How do we know if our plan worked? First, ask the patient, were your expectations met? Is your mobility improving? What's helping? What's not? Their perspective is paramount.
And from our side,
Compare current findings to the baseline. Did that redness on Miss Cavallo's sacrum get worse, become non-blanchable? Objectively measure ROM changes, muscle strength, observe alignment. Continually assess if the interventions are effective. Adapt the plan if needed.
so if outcomes aren't met,
Use critical thinking. Ask probing questions. Are there other ways we could help you be more active? How does needing help with dressing make you feel? Use their answers to adjust the care plan. Be flexible.
excellent. So we've really covered a lot today.
We have. It's been a deep dive into immobility, its effects, and crucially, the nurse's role in assessment, planning, intervention, and evaluation.
Yeah, from the systemic impacts, metabolic, respiratory, cardiovascular, all the way down to psychosocial and developmental.
And the practical skills positioning, safe transfers, DVT prevention, skincare, all grounded in that nursing process.
So as you move forward, maybe a final thought to consider.
Go for it.
Immobility, it isn't just about the physical inability to move. It's a really profound disruption to someone's entire sense of who they are, their independence, their connection to the world.
That's powerful. Our impact as nurses then goes way beyond just the physical tasks.
It touches every single aspect of their well-being.
Well, we really hope this deep dive has clarified things for you, maybe boosted your confidence as you continue your nursing journey. Keep learning, keep asking those questions.
And remember, you're part of a learning community. We're all in this together.
Thank you so much for joining us on this deep dive.